Hi, doctor.
Hey, 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 you know me. It's Dr. Cheryl Bryant Bruce, MD, also known as the Celebrity Doc, and here with my co-host, Hisham Elenmati, Hurricane H. And we are here with Chatters That Matter. Let's talk about it. We are here to educate, inform, and entertain you. And we have another great show for you today. We are bringing in our guest, which we let you know she was coming last week, Dr. Drexzell Glasker. Now, Dr. Drexzell, glad to have you here. You've got some really neat credentials behind your name. And so, probably these are credentials that Hurricane might not have even heard of before. So, we're going to talk about what you do.
I think I just figured one. Hey, doc, welcome to the show. And I'm in the healthcare, so I got to learn stuff every day, so it's a good thing.
Awesome. Thank you for having me, Dr. Bryant Bruce and Hurricane. This is a first probably for nurses. I've been a nurse for over 20 years, 30 years of healthcare experience. I grew up in a small town in the high desert of California. I'm the youngest of eight. And I started out as a single mom, as a teenager single mom, and figured I needed to do something really quick to make money to raise this child. So I went into respiratory therapy and did that for 19 years and got me a good living with a small child. And then I met the love of my life, um, Marine down in San Diego. I was in the travel contract and we got married. And he says, "What do you want to do?" I said, "Well, I've always wanted to be a nurse." So he goes, "Okay, you go back to school and become a nurse, and you can support me going to school and we'll do it back and forth." So I got my RN in Mission Viejo and became an RN. Worked in many different areas of nursing, started out in the operating room and moved on to critical care. And my husband says, "Okay, it's my turn. You got to." So he goes, "Okay." So we moved to Detroit, Michigan. That's where he's from. And he went to school, and I went to school right along with him. Got my BSN at University of Detroit Mercy, and experienced a healthcare system in our Black communities, which was pretty much underserved population, and saw a lot, learned a lot.
And now, Dr. Drex, I'm going to interrupt you here for a second because you're throwing out a lot of acronyms and people may not know what they are. So RN is registered nurse and BSN,
Yes,
Bachelor
bachelor's
of Science in
degree,
Nursing.
nursing science. I
Mhm.
apologize for that. And then moving on into my master's degree in nursing science, I became a family nurse practitioner with a school in Chicago, and it was an online based program. And then I continued on and got my doctor's degree in nursing practice at the same Chamberlain University in Chicago in healthcare systems leadership. And that's when I met Dr. Bruce Bryant through that journey.
Okay, so Dr. Glasker, you're considered what they call a mid-level practitioner. Had to think about that. I was going to say a midlife practitioner. It's like, no, that's not where I want to go. Mid-level practitioner. So, can you tell us what that means?
Sure. Uh, so mid-level, that's a very good question. Mid-level practitioners are practitioners that have learned to practice medicine and have gone through a rigorous program, academic program to prescribe, treat, diagnose, or if you want to go in the right order, it would be diagnose, treat, and prescribe at the level of a physician. Mid-level practitioners are in many of the states of the United States have physician overseers, and there are mid-level providers or practitioners that have earned full practice authority that does not need a physician overseer and practice at the same level as a physician. I'm in California, and California just received their full practice authority and working through the process. But having said that, we are helping the healthcare industry where there's not enough resources and providers, and there's not enough doctors to meet the need of our communities, and especially our underserved communities. So that's where we come in.
Perfect, perfect. So, can you tell us a little bit more about the educational process that you went through? Because you are a doctor, but you're not a doctor of medicine. You're a doctor of nursing practice. What is the difference?
That's a very good question. So with nursing, we start off, as I explained, your basic associate's degree nurse. So anyone can get an RN, which is a registered nursing degree, and start practicing nursing. Nursing has a terminal degree, which is evidence-based research, and we have two cohorts, you can call it. One is your PhD route, which is you're going to do research and create something. And the other is your DNP route, which is your Doctors of Nursing Practice, meaning you're taking the research that's already been proven and you're now going to translate it and into practice. So for a doctor of nursing practice, we take the research that's proven. For example, I worked on and looked at the diabetes in the United States. It's a huge problem. Well, in treating diabetes, there are diabetic patients that have to work and bring home groceries and food and pay bills just like everyone else, but they end up with the most significant work-related injuries. So in occupational medicine, I said, what is the top 3 work-related injuries that diabetic patients get? And the number 3 is shoulder injuries. And I go, now, how are the diabetic patients being treated in a traditional setting? And it's corticosteroid injections, which, okay, now what is the research showing the outcome of these corticosteroid injections to improve function and restore their function back to normal so they can do their job? Well, there's the side effects, and there are evidence out there that says there are alternatives. And so I found an alternative in the research and said, let's translate this into practice and so that we can have a better outcome. And so that's what I worked on for my DNP project. So a project for the DNP is translating into practice, and the PhD is creating and finding a problem solution. I hope that helps.
Okay, all right. So, but both have the title of doctor.
Yes.
Okay. So, is that not confusing to the patient? Do you have trouble with patients getting confused about it?
Absolutely, because it's new. Within the last, I would say within the last 10 years, the doctor of nursing practice and the PhD. Now, there are other professionals that says they're doctors, the chiropractor that gets the PhD, the dentist that gets a doctor's degree is a different type of medicine, right? So in your medical cohort, you have your MD, which is your most highly experienced and trained traditional doctor that patients understand is a doctor. We're not a doctor. We went a different route to get our doctor's degree. Your medical doctors are your highest and most educated when it comes to medicine. That is your traditional medicine doctor. Unfortunately, there's other cohorts that has a terminal degree, like your nursing. Another one would be your DOs. Your DOs are just like your medical doctors, but they train differently at an osteopathic medicine school, and they have a different study, which is similar and same as an MD, but more clinical, from what I understand.
Mm-hmm.
Then you have your dentist, which your dentists go to dental school, but that dental school earns you a doctor's degree. Then you have your physical therapists that go to their terminal degree, which is doctor so-and-so in physical therapy. That's a different terminal degree. Now, nurses, here we are. We've always been the frontline person you see at the bedside. And with nursing coming up, our industry has changed. And we have raised the ceiling to a rigorous program so that we can hold ourselves accountable for our practice. And the practice laws are changing now because there are so many more areas that need a mid-level provider like myself. So why not have that mid-level provider learn a little bit more about the research and the evidence and translate that into practice so that we can have better patient outcomes. Now, we're taking physicians like your medical doctors' evidence, and we're taking their evidence and we're implementing it into practice. So we're accommodating the medical doctor that done years and years and years of research to implement a practice. Now it's sitting there. Who's going to implement it and translate it into practice? We are. Us DNPs are going to implement and translate that into practice and say, hey, Dr. Beebe, I implemented and translated your research into practice. So it's a big shift and it's new. It's newer.
It is a big paradigm shift. What do you think was the driving force behind that paradigm shift?
I think the driving force is your nurse leadership. In nursing, we have some very scholar and stellar leadership in the whole healthcare system. And I think with not being enough providers to take care of the population that's growing, either we're going to sink or we're going to swim. So just because we took another route to get to where we're at doesn't mean that we can't practice at a higher level of practice. And I think I spent over, you say for 2 years for an RN, you say for a BSN, for bachelor's degree in science is another 3 years. And for master's degree in science is another 3 years. And for DNP is another 2.5 years. That gives you about 5, 6, 7, 8, 9, 10, 10.5 years of education under the nursing cohort to where we're at as a doctor's degree in nursing.
Mm-hmm. And how is that different than a physician's assistant? Because they're also mid-level providers, and a lot of times patients don't understand what the difference is between a nurse practitioner and a physician's assistant.
Very good question. From what I understand, a physician assistant cohort is adopted because the physicians realized they needed help. Physician assistant program was designed by physicians, by medical doctors. The medical doctor says we need help. So let's create our own assistant, and we're going to call them physician assistants. Core requirements to get into physician assistant are different from nursing. You can come into physician assistant without any bedside, any nursing, any medical experience, but come in with your prereqs of science courses and become a physician assistant.
Mm-hmm.
Physician assistant highest level is master's degree, master in science and physician assistants. From what I know, there isn't a doctoral level physician assistant. And I may be wrong. I haven't researched it.
No, as far as I know, there is not a doctoral level on physician assistants. So because they don't even have a BS as a physician assistant. It's a 2-year program. So obviously the 2-year program, they couldn't go on to get a doctoral unless they did a whole lot of training in between, because they would have to get that BS and then probably take the route of going for an MS and then on to receive their doctoral. But they stopped far short of that. And that doesn't not mean that they're not very skillful, particularly it depends on where they train. But for those who train in the military, those physician assistants were absolutely phenomenal. And just as kind of an indicator of the skill level, when I was in Massachusetts at Bay State Medical Center, now this was prior to the days of all of this computer tracking of everything and all. And they had 2 surgeons that were there, a husband and a wife team. And they were there, they were well respected, they were excellent surgeons. And then all of a sudden, poof, they were gone. And it was like, well, what happened to them? Well, as it turned out, and I'm not sure how it was discovered, but neither one of them had attended medical school.
Wow.
Apparently, they had probably bought certifications, but both of them had been in the military and worked as military PAs, and they learned the surgical skills, and they were so proficient at them, and had years of experience observing the surgeons and assisting the surgeons and such. And so they were like, "Hey, we can do that," and created this other life for themselves. And then they were gone. And, at that time, we all kind of wondered, well, did they show up someplace else, and just start the whole shtick all over again? Now
Yeah.
it's much harder to do that kind of stuff because everything is tracked by the internet, so.
Well, it's
But
credentialing and everything else going on, so you can't
yeah,
just practice without. Doesn't matter where you are. I mean, you eventually
yeah,
get
yeah,
caught up. So
Right.
yeah,
I had just a comment. I think one of the key things that you as a doctor and nurse practitioner, you do prescribe, medication to people, which normally a nurse would not, a physician assistant would not. I actually worked with a lot of NPs and DNPs, and you said 10 years ago, that's where kind of like the doctorate became, the I guess the relevant format. And
Mhm.
because before that, the NPs were able to work within a doctor's premise and they were able to basically execute on their directives. But that changed. And in the insurance world, we do have NPs on staff and DNPs actually that do medical, I guess, reviews and authorization and all the stuff. And they assist in a lot of ways. And also in the practices, I see them because I work with doctors in the community. They do have actually sometimes NPs that kind of fill in for their schedules, and they do see the patients normally. They prescribe, they do everything, and that's pretty much. I mean, it's helping a lot of the doctors. They cannot possibly sometimes recruit other doctors because mostly they want to be working with their own practice, and having NPs or DNPs with them serves a huge purpose. To your point, there are a lot of communities that need are underserved, they need the help. So the DNPs come in tremendously at a great help and definitely great asset and knowledge to help the community and service the patients.
Hurricane, that's great. And I just want to add to that too. And I have to give recognition to my NPs that paved the way for us. You have NPs that became NPs years ago before licensure. years
Mm-hmm.
before accreditation. And they were
Right.
advanced practice RNs that followed standardized procedures where they were able to diagnose and they were able to treat and they were able to write prescription, even narcotics, and manage care. Okay.
Hmm.
Over time, licensure, education, accreditation has evolved into this let's hold you accountable. And so now the institution, academia institution says, okay, we're going to create these programs. This is what the state want. And this is what I'm in the state of California. My standardized procedures are different from a person in the state of Florida, for example.
Mhm.
So it's good that they've ramped up their accreditations and they're holding nurses accountable for this.
And the state of California actually is pretty highly regulated. And as you said, in a number of states, you can actually practice independently and you can use the title doctor. But in California, that is not the case. They make
Not
a differentiation.
exactly. Very good point. So for me in the state of California, even though I have a doctor's degree in nursing practice, I can't put the name doctor first. It has to be Drexzell, Glasker, DNP, comma, FNP, which is Family Nurse Practitioner, comma, whatever other credentials fall behind that. There have been some nurses that are doctor's degree tell patients I'm the doctor. And we have to
Mhm.
be careful with that and make sure the patient know that I'm a doctor in nursing practice, not medical practice, not your
Mhm.
MD.
And I think that that is important so that the patient understands exactly who they're being seen by. And so the patient doesn't feel like they've been deceived. Because a lot of patients now, I mean, it's like at one point in time, it was very, very clear. The MD was the doctor, and then there were nurses and everything else. As we developed this mid-level provider sector, it became muddier for the patients, and they're not sure who's who and who does what. And then they kind of muddied the waters even further by changing so that now everybody's called a provider. They don't say your doctor is going to see you or a nurse practitioner is going to say you. A provider is going to see you. And for
Unfortunately, they're doing that. I don't agree with
yes,
that at all because it
yes.
just misses your physician. Um, Dr. Brian Bruce, the clinics that we work in, there should be a physician on staff, right?
Mhm.
But unfortunately, we just don't have enough physicians. And there's many days where a clinic will run with just nurse practitioners or just PAs. And the moral of the story is the patient's going to get treated, right?
Right.
The sadness of it is we just don't have enough doctors. I mean, I I don't know what to say about that, but I try to inform my patients very well. I go, if you would like to see a physician next time, I'm going to ask the scheduler to schedule you to see with the physician. And I like to see a physician on my note at least once
Hmm.
during the time of me treating and managing their condition.
Hmm.
It's
And I
necessary.
mean, I think one of the important things is that everybody understands what lane they're in. But you have a very, very high skill level, Dr. Glasker. And yet, and Dr. Glasser and I have been working together for the past few weeks, And there have been times when she's come to me and she said, hey, doc, this is what I'm doing, and what do you think about this? And we
Mhm.
have another doctor of nursing practice that is working with us as well. And she's a little bit newer at it. And she's very good at identifying
Mhm.
that, I'm not particularly comfortable with this, or, I'm just coming back over here. And so this is a little new to me. And so she knows where her skill level is. And that's an important thing. I mean, it's an important thing even with doctors, because as doctors, we have different levels of experience, and a lot of that's based on how many years you've actually been out there in the field. A lot of times we get the new residents that come out, they just complete their residency, they're new doctors, they're gung-ho, they got the title of doctor now, and they have difficulty in saying, I don't know, because it makes them feel like it's less and they should know. And one of the things that we had beat into us in our training was, you know what you need to know. And one of the most important things you need to know is what you don't know. And the second most important thing is where to find it.
Where to find it.
So it's okay not to know everything. And
Yeah.
because of our different layers of training, we're going to come with different skill sets. And although I'm a medical doctor, Dr.
Mhm.
Glasker brings a certain skill set that I have not necessarily trained in. And coming from a nursing background, your nurses are really your first interface with patients. And so they approach patients from a different level that we do. They actually tend to get more time with the patient, and they tend to get to know the patients better. Unless you're in a field like family practice as primary care doctors, we spend a lot more time with the patient. But if you really want to get the skinny on who the patient is, ask a nurse. Ask a nurse. And the nurses are very, very knowledgeable about medication, about procedures and practices, but most importantly, about who that patient is. And so we work as a team. And now that they have stepped into a new level of practice as mid-level practitioners, it's shifting. But again, we have to work as a team. Now, you work with other nurse practitioners and doctors of nursing practice. Do you find, from your standpoint, I know from my standpoint where it's at, but do you find that you run into nurses who kind of have a little bit of a chip on their shoulder and they want to be the MD. They want to be acknowledged as the MD, or even in the case with you, where you've done some fairly extensive research at a high level, where other nurse practitioners, other doctors of nursing, and even other MDs have issue with you. Do
Well,
you bump into
that,
that often?
yes, that's a good question. So there's always going to be hurricane, I mean, even in your industry, there's always going to be someone saying, I can do it better, or he's nobody. You know what I'm saying?
I think every industry has those.
Yes.
I'm the type of person that says, hey, look, you have a problem with me, let my skills speak for itself. Is the patient happy? Number one. Is the patient safe? Number two. Did I make a difference in that patient's life and get an early discharge? Number three. Now, when I'm not doing any of those, then you can come step to me and say, hey, I got a problem with you. I'm all ears. I want to learn what's going on.
Mhm.
But, I'm a sponge for learning new things. And it is what it is. And it's in every industry, any job, anywhere you go, you're going to have people like that. And
Huh.
I think my energy that I give out is more positive energy than negative. I just don't have room in my soul to embed negative energy. There's just too much, there's too many places to go, too many things to see, and people to take care of. I don't know.
Mhm.
Oh, that's terrific, and I think you hit on the money. First of all, you're right. Your action, your work is going to speak for itself, and you're right. Also, Doc, both of you, you said about if I don't know, there's always someone you can ask, and that should be, the for all of us, we're supposed to know. There's always someone who knows better, and the science and the healthcare itself is always ever developing and changing, and you have to update and upgrade almost every week, every day. There's articles, there's new studies and things, and unless you keep up with those things, I mean, there's conferences and stuff and new
Right.
discoveries and new medicinal, literally pioneer stuff, inventions that you can use and apply and techniques. That unless you keep up with your continuing education kind of concept, you're gonna have an issue. And by the way, I do appreciate all the NPs and all the nurses, because in the insurance world they're huge for our world, because I mean most of our care management teams are run by the NPs or NPs, and that's who actually does most of the evaluations and all stuff and work with the medical directors,
Yeah.
and so that's huge for us, and they do great work in the community. You hit something earlier that is powerful. When you go to a doctor today, there's a good chance you're not going to be able to meet a doctor, especially in the communities or on the cities, like 3 months away before you get an appointment with your agno MD. But
Right.
then you have the option to see an NP or DNP prior. And so, to your point, it is given access, at least to get your immediate. You go to urgent centers, I've been to many centers, and most of the folks that see there are DNPs or NPs, not doctors, at least not when I was there. I mean, they are available, but I guess
Mhm.
that's if you follow up and things like that. So it is an important role, and it does work hand in hand with our MDs. And without the MPs and NPs, I think the doctors themselves are going to suffer, because there is not enough, to your point, available, and we're just there's too many of us, and too
Yeah.
many
Right.
diseases, too many things going on in the healthcare. It's very
Yeah.
difficult.
Yeah.
Absolutely. And I mean, the healthcare situation that we are existing in now with the insurance and the computers and all that we have, the electronic medical records, everything that we have is taking time away from the
Mhm.
doctor-patient interaction. So we're having to see more and more and more patients in shorter and shorter and shorter amount of time without these mid-level providers there to assist us. You're going to get a lot of doctors that are just going to get completely burnt out. And
Mhm.
B, you're going to get a lot of patients that are frustrated when they can't get into the system. When you're having pain or you have an illness, you don't want to hear you can't see anybody for 3 months. Shoot, by the time I get to 3 months, I will have either healed myself or dropped dead, one of the two. So you don't want to hear about how you have to wait. There's not enough doctors. And people who come into the system that way, they're appreciative of having those mid-level providers who can very competently direct their care. And sure, there are some things that the mid-level provider is not going to know or may not have seen before, or that may actually be kind of out of their scope. And a good mid-level provider knows when to say when and to ask, just like a good primary care physician knows when to say when and seek a specialist or even the opinion of another primary care provider. And then, a nice example, I like to teach, and we had last week was a week when we had all sorts of what I call fascinoma patients come in. They come in with things that you heard about in medical school, but may not have seen before.
Yes.
And for me, because I was trained through the military, we saw a lot of unique things. And I had several patients last week that came in with those textbook kind of things that just aren't often seen in general practice. So I spent a lot of time last week doing actively engaged in teaching, because when I would get these things, I would pull them out of the rooms and say, come look at this and take your best guess. When you get one guess, take your best shot as to what the diagnosis is. And they were all head scratchers,
Yeah.
because even for me initially, because when you go into the ranch and it's a horse farm, you look for horses, you don't look for zebras. And when you come across the zebra, you have to stop and think, what the heck is that? Why is that there? And how is it different? And so some of those took me a couple of minutes to ask the right questions, and I had to stretch back in some cobwebs a couple of times to come up with these unusual diagnoses. And we had, one patient that came in, and she was giving one story, but then as we kind of ferreted out the answers to the questions, what she actually had was very different than what she was presenting with. So, and I went out and I grabbed my nurse practitioners and said, take a look at this. And they were excited, because these are things that, they may never see again in their career. But if they are the only one in the practice having seen it once,
Mm-hmm.
they'll be able to attend to it. And even their doctor might not be able to, because their doctor may not have seen it either. But, particularly if they're in the practice by themselves, which they oftentimes are now, particularly in the clinics that we're working in, it's not unusual for them to be by themselves, because we don't have enough physicians. And the physicians we do have are being rotated around to cover holes. So, it would not be unusual for one or two nurse practitioners to be there by themselves. And if they're there by themselves, if they've seen these things before, then it helps them.
Yes, definitely. Yeah. And that's teamwork. When you work together as a team and we respect each other's knowledge, we ping off from each other, and it's normal. You should do that. You should refer to your colleagues and say, hey, what do you think about this? And if you're not, then that's unfortunate for you.
Yeah, it is. And one of the things that is happening right now is the changes are, there's a lot of push and pull. There's turf wars, and folks trying to establish what their territories are. And sometimes that can get in the way of the teamwork. Have you experienced that, where knowledge isn't being shared with you appropriately?
Um, that's a very good question. And I think everyone at some point in time, and I'm not sure if they're doing it intentionally or it's just some people can't multitask and
Mhm.
teach. Everyone's not a teacher. So it's not
This,
necessarily that they're not sharing it with you, it's just that they only have enough information to get through and stay in that one lane, you know, and get through the day in that one lane. And that's okay. There are some people that are out there that do that very well. You won't get an ounce out of them.
right,
So,
right.
I wanted to share with you, Dr. Brian Bruce, there are nurse practitioners with the master's degree that has either family practice, pediatric, adult gerontology, acute care, or psychiatric background. So those are the
Mhm.
cohorts for nurse practitioners that are opening their own practice. We don't
Right.
need necessarily in some states, I can't remember how many states, but there's close to 20 something odd states that are full practice authority, where nurse
Mhm.
practitioners have been granted full practice authority without physician overseers. And America needs it. There's a lot of
Mhm.
rural country in America that needs clinic We need to open more clinics. We need more healthcare providers out in the woods and the backwoods and the front woods, the cities. We need more. And nurses are stepping up and they're doing it. They're doing a great job at opening their own practice and getting people seen. And we do know where to refer. We have to refer to a physician that is specialized, more knowledgeable, and that can help make a difference in patient outcome.
Right. Now, educate me. Are you all able to supervise physician's assistants?
That's a very good question. And the answer is no. We're a different cohort.
Mhm.
Assistants come under a whole different academia cohort. And for nurses, we supervise each other, our cohort, but not a physician assistant, not that I know of.
Okay. Yeah, I kind of suspected that might be the case, but I really wasn't 100% sure about that.
Yeah, their training is very different than our training. Yeah.
Mhm. Yeah. So, where is an area where a doctor of nursing practice would actually, well, you've actually already said that. We have these rural communities, and a doctor of nursing practice can be an exceptional asset to a community like that that might have a difficult time pulling a a physician.
Hmm.
And even, I mean, even for physicians, these rural communities can be an exceptional place to go if they're in primary care. Because, like for myself, I am integrative family medicine. As a family medicine physician, I am able to deliver babies. I'm able to do surgery. Yet in the cities where I'm working, right now I'm in Sacramento, I was in the Bay Area, I've been down in LA, Houston, all these cities that I've worked in. I have not delivered babies. I have not done surgery because you have all of the specialties there, and it really comes kind of down to malpractice. A lot of the hospitals are concerned about their liability if there's a lawsuit. And even though a family practitioner may be just as skilled, and particularly, I mean, family practitioners, we started the whole ER thing before they had ER residencies. And yet in the cities, it's hard for us to get those jobs because the hospitals are worried about the liability. We're able to go out into the rural communities, and there, because you don't have all of the specialists coming in, we're able to practice in those communities because there is such tremendous need.
Hmm.
I'm seeing it being very much the same for you all as doctors of nursing practice.
Well, see, I need to clarify something. Doctor of nursing practice is a different degree. In
Hmm.
order to be a nurse practitioner is a different degree. So
Right.
not all doctors of nursing practice are nurse practitioners.
Oh, interesting.
Yes.
Okay, that's an
Thought I
interesting
need to
distinction.
clarify that because in nursing, you can go administrative route or
Right.
you can go clinical and become a nurse practitioner.
Okay, see, we don't have that differentiation in medical. You can be an administrative physician, but you're still an MD. So
Right.
that's an interesting
Yeah.
distinction.
So when people ask me, oh, Drexzell, you got your DNP. Are you a nurse practitioner? So that's why you see the title FNP-C, that's Family Nurse Practitioner certified. That means I sat for the boards and passed the board examination to be a family nurse practitioner. Now, what is a family nurse practitioner? That's the nurse practitioner that can see anyone from cradle to grave.
Hmm.
So I see all ages,
Hmm.
and I am practicing within my scope of practice.
Right,
Now,
right.
you have some nurse practitioners that only focus on one scope. For example, your pediatric nurse practitioner. That's just one scope. The other one is adult gerontology. That's only the adult population. That's one scope. So you have to look at the title behind the name to get a better understanding and ask the questions. What type of nurse practitioner are you? What are you licensed and credentialed in? Now, in the doctorate degree, we do not have a clinical doctorate degree in nursing that would be equivalent to a medical doctor. We don't have that. We have a doctor's degree in healthcare administration. So I'm a healthcare systems leadership doctor's degree. Yeah.
Interesting. That's like I said, that's a really interesting distinction, and thank you for that clarification.
Yes, I was thinking about it, I go, I need to clarify that because not all DNPs are clinical. They may be administrative only in the hospital.
Right.
Yeah.
Right. Yeah, that is really interesting. Now, what are some of the things that, if you could pick out a couple of points about what you do that they may be pet peeves for you, or they may be points that you really think that people just don't get about what you do, what would those be?
That's a good question. For example, say we're in the clinic and I get a trauma patient that comes in. It was an accident, a work injury, and it needs a suturing or laceration repair. So I think patients don't get it when I go, okay, we're going to suture you up, get you a tetanus shot, get you some pain medication, and I'll see you back tomorrow. They're like, you doctor? I'm like, no, I'm a nurse practitioner. Would you like to see a doctor instead? Because, you can. Oh, no, it's okay. It's okay. You can do that. Okay, you can do that. So even patients are confused about, oh, she's doing a procedure on me and she's not a doctor. She's a nurse practitioner. That would be probably the most frequent situation that occurs. Yeah.
Yeah, and I can see that because in actually really pretty much the recent months, really, and again with this whole provider tag thing, I very regularly get asked now when I come into the room, okay, so what are you? Are you a doctor? Are you a PA? Are you a nurse practitioner? And then what is this doctor nurse practitioner thing? What are you?
I see. Yeah,
Yeah,
that's
so
interesting.
yeah, I mean, it'll be a little while with us educating patients so that they understand what those differentiators are, and so that they become comfortable with the care level that they'll receive. Because, I mean, you're an excellent provider, and yet sometimes I'll get pushback and say, oh, well, I only want to see a doctor.
Yeah.
And oftentimes they won't have such a complicated thing that really warrants that only a doctor can see them, because I mean your scope of practice is so large, and your knowledge base is so large that most of the things that we see in our particular facility are well within your scope of practice. And there's not a reason that a patient shouldn't be absolutely thrilled with receiving the level of care that they would get from you. And yet they'll give that pushback because they don't know, they don't understand.
They
Well, I
like
think
to shop around for who's going to listen to them or who's going to give them what they want.
A lot of that.
There's a lot of shoppers out there. And it's unfortunate that the physicians have to go through what they go through to explain themselves. When you walk in a room, it used to be you're the doctor. There was no mid-level, there weren't many, I shouldn't say none, but there weren't many mid-level providers to where you had to explain yourself. But I introduce myself as nurse practitioner. I don't even use the doctor, I don't use the DNP. I just say, hi, I'm Drexzell, the nurse practitioner. You know, it makes it easier for them to understand, because the minute I have to explain the doctor and the DNP, it's not necessary.
Mm-hmm.
I think we can attribute that to the fact that there's not enough, I think, promotion about DNP programs and the NPs in general. Even when you look at entertainment and movies and stuff, you don't hear a lot of NPs in there as characters. You hear about the doctors, and it's not. And again, for what it's worth, I mean, it may be a lack of. Maybe somebody can listen to this and say, "Hey, it's time for us to do a show about the NPs." Maybe you never know.
Yeah.
But it will
Right,
be
right.
it will be a very, I mean, imagine this. I mean, what you guys go through. We can take the pandemic as an example. NPs
Right.
played a huge role, right?
Yes.
But because of that, there's lack of understanding or education or even just knowledge about the scope of the work. I mean, in my world, I know because we have a huge interaction with the NPs. But a lot
Yes.
of common folks are not going to have that interaction, to your point, unless they go to a clinic and then they see a provider and like, well, I want to see my doctor. Who are you? And it becomes challenging, and they
Yeah.
don't know the difference and they don't even know that sometimes you can write the prescription at that level. And I'm like, well, are you going to write me this? Can I get medication? And that's going to be a challenge. And I think we need
Right.
more education. We need more awareness. And again, talk shows like this and maybe some programs can do a bit more justice. Maybe, I don't know if there are groups of NPs nationally that are actually doing some movement about it that also can help. I think there's a need for that.
Kind of
Thank
like
you
a
so much.
PSA, a public service announcement,
I,
but
I yes. Yeah. The
mhm.
platform is needed. Thank you so much, because I'm involved in a bunch of groups online, social media. We don't have a voice, nor do we have a platform. There
Mhm.
are platforms out there, they're excellent, but they're limited to members or providers
Right,
only. You know,
right.
it's not, I come from a small town, and those folks don't know. They think I'm a doctor, and I have to tell them I'm not a doctor, I'm a nurse practitioner. Well, what's that?
Mhm.
You mean, okay. There's a huge knowledge deficit out there on what a nurse practitioner is and what we do. Yeah.
You
And
do a lot.
I mean, it's I appreciate your ability and your comfort level in that acknowledgement, because I have worked with a couple of nurse practitioners that had PhDs, and we would bump up into each other because it was like the fact that I had an MD was threatening to them.
Mhm.
And, they wanted to assert that I'm just as good as you are. And I'm like, I'm not saying that you're not just as good as I am at what you do, but what we do and what we're trained in is fundamentally different.
Different. Yes. And probably because most of my nursing career, I've worked in teaching institutions. I've
Hmm.
worked at the UC system. I worked at LA County Hospital. I worked with residents going through residency. So I have an appreciation of what it is that you go through. And I see
Right.
it. I understand it. Whereas to some of the other folks don't. They may have an imagination of what medical school is like. I could have went to medical school, but I didn't go that route. I went the nursing route. I needed more freedom.
Well, probably.
I'm sorry. I had babies to raise.
Yeah. Okay, I raised babies and did it at the same time. I'm not sure that I would
Yes,
recommend
you
comparing
did.
it to someone
And
who
so
did
some of
this.
my other colleagues did. But,
Yeah,
something
it's
about being a traveling nurse. You check in
mhm.
for 12 hours and you check out.
Right, right. And I actually came up back in the olden days when the training wasn't so regulated, because now it's really regulated down so they can only put in so many hours and all. But we used to have what was called long call and then short call, and
Yeah.
then you were off call. But when you were off call, you still were working. So there would be periods of time when we actually worked for 36 hours straight.
Yeah.
And it was grueling, but also mentally, you had to always be on point.
Mhm.
And some days were better than others, but you still had to stay sharp. You still had to stay on point, and you still had to be accountable for what you did.
Doctor,
So,
doctor, we lost you for a
Yeah.
minute. So if
uh-huh.
you don't, yeah, we
Like
No,
there's interception with my cell phone. Can you hear me now?
yes.
I can. I can, and I don't think it
Okay.
was your cell phone per se. We went to black for a minute there with the little whirly-gigs rolling, so we were all kind of out of commission for a minute.
Hey, hey, listen, we're like East Coast, West Coast, and I guess everybody is on the the internet these days.
Right,
Uh,
right. Yeah, it is Sunday afternoon, so a lot of people are home and on the internet, at work they can't do that, but now the waves are loaded up.
And we got
So
snow in California too. Southern California,
yes,
Northern
we
California.
got snow in California in some of the areas where there usually is not snow. I mean, I went to high school in Sacramento, and I can only remember one time during the time I was in high school where there was snow, and we had snow flurries uh, yesterday, the day before yesterday, and it has been cold. It has really been cold.
well, it's funny. You guys are talking about snow in California, and we have not yet had snow in Jersey. So, so I'm sorry.
Wow.
Yeah, I hope I don't jinx it, but so far so
Well,
good. I mean,
Yeah,
um,
I can usually we've had a couple of blizzards already.
so
and
doctor,
I have one question
yes.
from your standpoint of nurse practitioners in Jersey. Can you explain to me what your interactions have been like? I mean, have it been good interactions or questionable interactions with your mid-level providers or nurse practitioners?
Great question. So two things. I actually live in Jersey and I work in New York, but I do have my personal I guess life is in Jersey, and so
Mhm.
therefore I do interact with them, and it's been great actually. I have no ill feelings about any. I believe me, I'm pretty vocal and I'm in the healthcare, so I would claim something if it's needed. But no, I love my NPs and they've been good and they do come in a great mode. As a matter of fact, couple of weeks back, I wasn't feeling good. I went to the urgent center, and it was an NP. It was a great interaction. They did what they had to do. I was doing good. They gave me something to fix the immediate problem, and it was great. And it's pretty, very very up there in terms of the expectation that you would have as a patient.
Mhm.
And again, for me personally, because I can tell you about 12 years ago, I was working in one of the largest nursing companies in New York. And, I was in the insurance plan that they had. And so all our colleagues, 90% were nurses or NPs, and they were like home visitor nurses type of, level of nurses, but they had different levels, of course, entry nurses, they have the NPs, and so we've done a lot of work. Even it was the time for Sandy, for example, the storm. They did a lot of work in the community, and they were really proactive in delivering the services in the community. So I'm a fan. I'm a fan of nurses, NPs, doctors. Again, because on the maybe people are not a fan of us because we're the payers, and that's another touchy discussion about the insurance world. But it is a necessary evil, I would say. Unfortunately, it's part of the system. But I do happen to work in an area of it that is more patient driven or patient centric or member centric, and that is the government program. So it's Medicare and all and Advantage. So it's a little different. It's kind of restricted, but we do work a lot with the NPs. So again, I interact with them in the business aspect of it. I interact with them as a person in both states, New York and New Jersey, and I have not felt any otherwise about them whereby they're not really up to where they need to be in terms of their practice or their qualifications. I think they're very highly efficient, and they do their job terrific. So
Yeah,
kudos to all of them. I have not had any problems. So hey, I'm not necessarily the judge of it, but I can tell you.
yeah. I think your nurse
Yeah.
practitioners would love to hear that. I've had situations where a radiologist would call me and want to speak to me. And I go, hi, this is Drexzell, nurse practitioner. And they start asking me questions about my training. Like, now, how did you get your nurse practitioner? And the moral of the story was, how did you know to order for this image? How did you know? And he asked me questions like he was interviewing me. Like, how did you know?
Now
And
let's talk about that a little bit because this is Black History Month, and one of the things out there is you are an African American provider. You
Mhm.
are a mid-level African American provider. So you've got two things going on there that can impact on those interactions. Can you tell us about your struggle as an African American provider carving this trailblazing in the mid-level world?
No disrespect to any other culture, okay? We all have our stories of struggle.
Mhm.
Um, I think the awareness of Black history and Black History Month comes with the awareness of any other cultural history month,
Mhm.
Latino, Hispanic, Indian, and the list goes on and on. But specifically to African American history, we no longer need to be afraid that we are African American providers. We need to
Right.
verbalize that we are African American providers. And it's okay for us to verbalize our struggles. My struggle
Mhm.
was real. I mean,
Mhm.
it was so real that we raised our children in a predominantly all white community in South Orange County. Now, you go figure. I was the only Black nurse on staff at a trauma center. And how did we end up in South Orange County? My husband was stationed in San Onofre, which is right there. And we just end up in that area. And we decided our church home was here. We're going to raise our children here. And we're just going to be here. And I've had nursing professors say to me, oh, Drexzell, because you're a respiratory therapist, you're going to make it. Not because uh, you're not going to make it because you're Black. They had to find a reason that I was going to make it because I had previous respiratory therapy experience. And
Mhm.
I was the only Black person graduating in my class at a predominantly white community. And, I never thought anything of it because I wasn't raised to see color. I was raised as a military brat, and everyone in our
Mhm.
community was of different color. And we weren't
Yes.
taught to be prejudiced or biased of color. And so I was naive to it. I was naive to any of it. So, the struggle that I say was real is as I start waking up and I start hearing little bits and pieces of it, and I start recognizing different treatment, then I go,
Mhm.
I guess that does exist. I just never looked for it. But,
Mhm.
I move and push through it. You navigate through life and you just get through it. And I think that military background of my mom saying, you don't look at color or race, you just get to where you need to go the best way you
Right.
can.
Right. And
Yeah.
as a as a military brat also, I really can say that that was a very rich way to grow up because we had such exposure to such a cross section of different people from all cultural backgrounds, from all racial backgrounds. You had to work together and you learned a lot about each other. So military brats tend to be very well rounded and tend to have the perspective that you just voiced.
Yes, exactly.
Well, Dr. Drexzell Glasker, it has been absolutely wonderful having you here and having you enlighten us about this mid-level gray section that's there that, people just really don't know what it's all about. And because of you, hopefully someone out there listening the next time that they see a nurse practitioner walk in, they won't have that same qualm about, oh, well, I was supposed to see a doctor, and you're not a doctor. Oh, it says doctor on your jacket. What are you? Hopefully they'll have more of a comfort level. They'll have more of an understanding. And when you are giving them, imparting information on them, I mean, Dr. Glasker has a wonderful protocol that she uses for injecting joints. And most of the doctors don't know anything about it. So she's definitely bringing something to the clinic that will help the patients out. And hopefully, by having seen the show, the patients will be more able to receive it and to acknowledge the expertise that mid levels are bringing to us. So I'm glad you were able to come through and share that with us and to clarify a lot of things for us.
Thank you,
Wonderful.
doctor.
Thank you for having me. Thank you, Hurricane. Appreciate you.
Pleasure.
Now, Hurricane, Dr. Glasker had a special request because she was a little bit disappointed in the last show because she was waiting for us to dance.
Oh, let's dance. You don't have to ask twice. I got this. All right. Well, again, we can just start doing our thing. I mean, we do it, the three of us, right? We're gonna go
That's
left.
right.
We're gonna go right. We're gonna go left and right. And actually, people are watching with us right now. Just join the movement. Here we go. Left and right and left and right and left. We gotta synchronize, baby. We gotta synchronize.
She's
Okay.
here.
So
So,
we go 3, 2, 1, and we go left. All right, 3, 2, 1, left and right and left. There we
okay.
go. And right. Oh, that's fun. Hey, listen, it is all we educate, we enlighten, we have to inspire, motivate, but also we have to have fun. I think life is about that. And there's so much. Like you said earlier, something, doctor, that was powerful. But you have too much positive energy to dwell on negative. I think that's really a big deal. And I think for folks that are watching and listening right now, we want to just give that energy out. And I know we are through a screen or through a voice and audio, but I guarantee you, just listening to this, they'll be like, "Yeah, I feel the vibe," and we want you to see the vibe, and we want you to feel the vibe. And there's
Right.
nothing more. I mean, it's a Sunday. Everybody's chilling, as we said earlier. Probably the internet is booming right now. But yeah, listen, have fun. There's always that. I mean, we have to enjoy, today. We have to enjoy everything. We have to just do it. So, was that a good thing? Do we want to do it again?
Yes.
I mean, I listen.
Music we can cue
Hey,
up to work with
what was that?
it. I said, do we have any music that we can cue up to work with it?
Or let's see. Music. I mean, let me see. Ah, I gotta figure out. I gotta get some music on. Give me a second. Maybe.
Music. Yeah.
Let me see. Let me
While
see.
while he's working out the music, Dr. Glasker, if
Yes.
someone were to want to contact you to ask about mid-level providers or to have you speak, how would we get in contact with you?
You'll contact me at D like David Glasker, my last name, Glasker, the number 0 at gmail.com.
And we'll have that posted to the site so that people can find it easily.
Okay.
So I have good news and bad news. I have the music, but if we play it right now, because we are live on Facebook and Instagram, it's gonna go copyright. So that may be a problem.
All right. No worries. Well, you got to play with
Yeah.
it at least anyway.
Yeah, when the show closes, we can actually play the music and just get some boogie on. So it's ready. But I know it will get a copyright kick, and then it will just destroy the value of the show as it's airing right now. So yeah, so you got to be sensitive with copyrights, and we follow the rules.
Absolutely. But we're going to get our licensing so that we can play whatever music we want to play and have fun with it.
I do have that. The problem is you got to whitelist it with all the channels and all the stuff before they can. So you still get a problem, and somebody reports it, and you have to send it. It's a pain. I mean, I deal with that. I mean, I have shows from 2 years ago that's still popping up copyright. Oh my God. Okay, and you have to send them information.
Right.
But we'll get there. We get there, folks.
All right. Well, it has been wonderful again having you, Dr. Drexzell Glasker, and we have enjoyed all of the information that you brought. This will be, it's being broadcast live all over, but it will also go evergreen on several different channels, including YouTube, so that this information will be out there for people to look at and review and to share with each other and share with friends. Do feel free to share it with as many people as you can so that we can educate people on these mid-level providers, because I know that you all do need that platform. And you're growing in numbers, you're growing in strength, and certainly you're growing in knowledge, and we'll definitely be seeing more and more mid-level providers as the years are rolling on here. So thank you for doing what you do. Absolutely.
Thank you, Doc.
And this is Chatters That Matter that you've been listening to. I am your show host, Dr. Cheryl Bryant Bruce, MD, here with my co-host, Hisha Melamati, Hurricane H. We hope that you'll come back and join us again next week. We're going to have a special celebrity guest, and that one will be a surprise. So make sure you come and check it out and see who we have here for you. We are here to educate, inform, and to entertain. Go to our website, like us, share us, and let's talk about it.
Bye, everyone.
Bye-bye.